Good evening, everyone. And today we are going to have the quiz session on benchmarking, which we have discussed in the previous weeks. So, as usual, I would like to read out the question and then expect the participants to try to answer, and then we'll go for the explanation and see what's the right answer. And after this quiz, we will go through the accreditation part one, inshallah. So, jumping directly to the questions here. Today's first question is a scenario based one. So, a freestanding radiology service center's indicators include the measurement of patient wait times, timeliness of reports, timely follow up on abnormal reports, and response time to urgent exam calls, as well as individual practitioner data. The information is collected by staff using various data collection tools. The QM professional aggregates it quarterly and year to date, reports it to the administrative and medical directors, and disseminates the report to all medical groups and other providers with whom they have contracts. Use this information in answering the questions. There are two questions in this scenario. In the first question, which step is missing from this QM process? That's the question. Is it indicator development? Is it data collection? Is it analysis by peers? Or is it reporting? What's the right answer? Unmute yourself and try to attempt the answer.
Analysis by peers.
Right. So here the correct answer is analysis by peers. See, the question is simply asking that has given the entire scenario, and here while reading the scenario itself, you might have gone through what exactly the clues are. You have seen aggregate the data. Yes, data collection is there. Then reporting is there, and then when they are talking about disseminates the data to the top management, yes, that's also the reporting. And then indicator development, in the very first para you see that they are measuring patient wait times, timeliness of reports, timely follow-up and everything, right? So they are doing indicator development, they are collecting the data, and then they are reporting it to the directors and disseminating to medical groups with whom they have contracts. So all three are covered. All these three are covered. The only one missing is analysis by peers. What exactly is it? Here in the question, you don't see that the data that is aggregated is analyzed or judged, whether the data collection methodology was acceptable or not, was there any concern regarding the process and all, right? So there was no complete analysis of the data, and hence the correct answer is analysis by peers. Now, in the same scenario, another question is, considering total quality management philosophy and continuous quality improvement process, who is most responsible for the effective implementation of quality management activities in this radiology service center? Options are quality professional and medical director, council of organization leaders, governing board, or physicians. Who among these is most responsible for effective implementation of quality management activities? What's your answer?
Letter B, Doctor.
Sorry, option?
Option B.
You're saying option A, quality professional medical director?
B, Doctor. Council of Organization
Okay, right.
Leaders.
Okay. You are saying option B, Council of Organization Leaders. Right. This is in a way like, remember, this is how close the CPHQ questions are in the exam. Here, this is a sort of trap. Again, I mean, like, I don't find fault with you choosing option B, but most of the candidates will actually do it because they have seen this most responsible one. Obviously, that comes because During sessions, we generally say this responsibility, the final responsibility, final authority, organization leader, governing body, or something like that, right? So, in a way, like there's always a confusion between organization leaders, governing board, as far when you come across the most responsible word. But here in this particular question, remember it's talking about most responsible as far as effective implementation is concerned. So, it's very important for us to look into the other clues as well. Now, you all know physicians obviously like they are participants in peer review and clinical judgment, but here there's no role for them. Here there may be a dilemma between all these three options, but here you know quality professionals and medical directors, these are the operationally responsible people on the ground to actually run the data process and everything, right? Because medical director here provides the clinical authority, okay, who looks after the physician buy-in and radiologist thing. Quality professional is the most responsible person alongside the ground staff. Here, effective implementation is the key apart from the most responsible one. I don't find fault with you by for choosing option B or C, because obviously council of organization leaders means it's when you see this organization wide, obviously most responsible, you might be tempted to go with option B or C, but again that's a sort of oversight body. That's a steering committee. Council of organization leaders is like quality steering committee. They are responsible for supervision, oversight, for framing how the program of TQM or CQI is. But effective implementation is always the ground level staff. I mean, like here, it's the medical director looking after the medical things in association with the quality professional. Okay, if it was something regarding the apex council for quality, yes, obviously it's the council of organization leaders, and the ultimate responsibility of quality is always governing body. Just remember these sort of distinctions, and you're good to go. I hope you understood why option A is the right answer. Okay. Now, coming to the next question, prospective review may be beneficial unless option A, the patient is having elective total knee replacement. B, the patient is being readmitted for bypass surgery following heart catheterization. Option C, the patient was admitted through ED for a fractured hip. Option D, the patient is a member of managed care organization. What's your answer? Here the questions are, sorry.
Option C, doctor.
Option C, right. That's the right answer. See, the question's asking like prospective review. You know what prospective review is. Okay. Prospective review is checking before the admission or at the time of admission whether the care is appropriate or not here. Okay. In such, when is this prospective review beneficial? In following four scenarios. Okay. When it is not, in a way, because three statements in three scenarios it is beneficial, and in one scenario it is not, because okay, this is a thing which we need to look into. So obviously, unless you are looking for the scenario where there is no opportunity or benefit for reviewing before the care happens, right? Now, in case of the patient having elective total knee replacement, this is an elective admission. It's scheduled in advance, right? Here we know prospective review works, and you can check appropriateness, you can check pre-authorization plan before admission itself. So this is where prospective review is beneficial. So this is not the answer for this question. The patient is being readmitted for bypass surgery following heart catheterization. Again, this is also planned and scheduled. Okay, now because in earlier admission it is assumed that they had angio and was admitted for bypass surgery. Now it's a sort of planned one. It's not an initial admission. Okay. Now option D, the patient is a member of a managed care organization. Yes, because in managed care organization member, I mean, like here MCOs actually rely heavily on prospective review for elective and planned care. So in a way, like here also prospective review may be helpful. But here option C, the clear cut scenario, the patient was admitted through ED for fracture of hip. So this is a sort of emergency unplanned admission. There's no advance notice. There's nothing, no information regarding an admission happening of that sorts, right? So here there is no time before admission to conduct a review of the patient's needs. So here the prospective review may not be 100% beneficial. Okay, so option C is the right answer. Now, coming to the next question. Who usually makes the final decision regarding credentialing in a managed care organization? Is it governing body? Is it credentialing committee? Is it quality improvement committee? Or is CMO? What's your answer?
Credentialing committee. They will review, approve, and finalize the decision for credentialing.
You are saying credentialing committee?
Yes, doctor.
Right. This is the right answer. Again, there's a small nuance in this particular question for everyone. Here, the scenario is regarding the final decision regarding credentialing in managed care organization. Okay, so in general, in healthcare organization, most of the times we all know the final and ultimate authority regarding credentialing lies with governing body, but governing body is the final one who signs off everything. Okay, so that may be assumed as a final decision, right? So they hold ultimate legal and ethical accountability for all credentialing decisions, but it is the credentialing committee, okay, specifically in managed care organizations according to NCQS standards. Okay, all credentialing decisions must be done through formal peer review process, that is through credentialing committee. Okay, here the governing body delegates its final authority of credentialing to the credentialing committee. Okay, who constitutes credentialing committee? It constitutes of experts, the peer group. Okay, so though the governing body holds the legal and ethical accountability for the decisions, it is the credentialing committee who takes the final decision, because they evaluate, they see, they completely go through the credentialing process, and then they will finally take a decision regarding the credentialing of a practitioner. Okay, that's more of an operational case by case decision. I hope you understand. No confusion at all here. If it was the final responsibility or the legal or ethical accountability, then it would have been governing body. But in managed care organizations, due to NCQA standards, it is always the credentialing committee, which is made of participating practitioners, to have a final decision regarding credentialing. Okay, so there's no sort of confusion over here. Sometimes you may come across, you may be stumbled upon this chief medical officer option also, but again remember, here the chief medical officer is more of an operational and clinical leadership role, who may suggest, in a way, like who may advise the credentialing committee, but the final say would be of credentialing committee. Okay. Now, coming to the next question. Who makes the final decision regarding reappointment to the medical professional staff in a hospital? Is it governing body? Is it the medical staff executive committee? Is it credentialing committee, or is it medical staff as a whole? What's your option? What's your answer?
Governing body.
All right. Here, the correct answer is the governing body, because there's no other, what do you say, trap over here. It's simple final decision regarding reappointment, right? So, in hospitals, this is not in MCOs, in hospitals, final decision regarding reappointments. So, you should know that governing body in hospitals, the board holds ultimate legal responsibility again. and they may take recommendations from the medical director or the credentialing committee or whoever it is for the reappointment, and then they take the final decision because that's the board that is finally signing off the reappointment thing. Okay, so there's no question over here, right? Now, medical staff executive committee, now they may review credentials, peer input and do, but the final decision is always the governing body. Same with credentialing committee, they do the complete credentialing process, verification, review of everything, but again they will send it to the governing body and they'll finally sign off. Medical staff as a whole, obviously that doesn't that's not how it works, right? Now, coming to the next question. Which of the following is an untrue statement concerning licensed independent practitioners? Okay, so here are the four statements. It's asking what is the untrue statement. Untrue is false statement. Three are the right ones related to licensed independent practitioners, one is not. Which of the following is the wrong one? Any licensed independent practitioner is potentially eligible for medical or professional staff membership. Option B, LIPs who are not members of the medical or professional staff may treat patients. Option C, all licensed independent practitioners must be credentialed and privileged in order to treat patients. Option D, non-physician licensed independent practitioners practice with supervision within licensure limit. What's your answer?
Option D, Doc.
B.
D,
B.
D.
Yeah.
Yeah, option D. Right. So A, B, C are the true statements related to LIPs. D is not. Why? Because see, what is LIP? We all know. Independent practitioner, licensed independent practitioner. Here, by definition itself, they are licensed to practice without direction or supervision within their scope of licensure. This is all what we got to know in our previous session also. So in that way, we know that they are truly independent in practicing, no supervision is required. Now, there may be some confusion regarding option B here, but see, any licensed independent practitioner is potentially eligible for a medical professional staff membership. Yes, any LIP can apply and can go through actual appointment cycle and everything and then go for credentialing privileging. That's all. We all know that's a true statement. Option B, LIPs who are not members of medical professional staff can treat patients. Yes. Okay. Because non-member LIPs will also be there who can hold temporary privileges, or there may be telemedicine practitioners also. Okay, or there may be some specific arrangements with those LIPs who are not even the medical members of that particular organization. They can still treat the patients without full medical staff membership in some organizations because they are licensed independent practitioners. By law, legally, they are allowed. Option C, all LIPs must be credentialed and privileged in order to treat patients. Yes, obviously. All LIPs have to go through credentialing and privileging process. Whether they are members or not, they should have credentialed and they should have been privileged. Okay. Now, option D, non-physicians LIPs practice with supervision within license. Again, this goes against the definition of the very LIP which we are discussing. Okay, so LIPs practice independently. They don't require supervision. Okay, but within their license limits itself, that's where practice with supervision is something which is not true. So the correct option is option D. Now, coming to the next question. Reappointment to an organized medical or professional staff generally includes all except what? Option A, reappraisal by uniform criteria. Option B, reappraisal annually. Option C, review of current competency. Or option D, approval by the governing body. Which of this is not typically part of a reappointment process? What's your answer?
C.
Okay.
Is it
Someone
C?
said, okay. Someone saying review of current competency is not included in reappointment. Okay. So we'll
Option
go
B,
through each.
Doctor.
Option B. Someone saying
Yes.
option B. Someone says option C. Okay, let's go through each option again because you have taken a little bit longer time to come to this answer. So here the question says reappointment to an organized medical or professional staff generally includes all. So there are four sort of statements. In during reappointment, three are the right ones, one is not. Okay, so here general includes all except. So three are the right ones, one is not. Now coming to option A, reappraisal by uniform criteria. So here reappointment must apply consistent and uniform standards across all practitioners in the same category, we all know. So obviously reappraisal by uniform criteria is a true statement. So obviously that's the right one. Now, coming to option D, approval by governing body. Obviously, this is standard. The governing body holds final authority to approve reappointment. We all know. In the previous questions also we discussed this. So this is also a right statement. Now, option C, review of current competency. See, this is also a standard process, a standard thing that is involved in reappointment because competency review based on their OPP data is very much a big key for reappointment because during the reappraisals we know we'll go through all the data that is gathered of that particular practitioner for his time with the organization in the previous 2 years, their FPPs, their OPPs, every data, and then we'll see how competent he is regarding his privileges that are there and everything, and we'll review his competency now. Obviously, this is a right statement regarding the reappointment. Okay, now reappraisal annually. So this is an odd man out. Why? Because you see, we all know reappraisal is in a way like reappointment is done at least every 2 years or 2 to 3 years in a way, but mostly it is 2 years. So this is not an annual event, right? So reappraisal annually is part of ongoing evaluation, right? So it's an ongoing performance monitoring, which is continuous. But the formal reappointment and reappraisal is not an annual event. That's biennial event or once in 2 to 3 years. So obviously, this is an odd man out. So the all except. So we are looking for a statement that is not related to reappointment. So this is a right answer. Okay. All the other three are the related sort of options, and this is an outlier and the right answer for this question. Now, coming to the next question. In a managed care organization, an appeal following a denial of care or benefits. Option A may be reviewed by an independent external review process. B is a formal grievance filed by a patient. Option C is limited to insurance coverage issues. Option D may be reviewed by a patient advocacy group process. What's your answer?
Option A.
B.
Option. Okay, someone's saying option A, someone's saying option B. Right. So let's go through. Here the question is asking like when an MCO or a managed care organization denies care or a benefit, okay, and if a member appeals, which statement is correct in that regarding that appeal process out of the four that are given? Okay, here option A. Before going to option A, we'll see from B to D. Option B is a formal grievance filed by a patient. Okay. This is a sort of mix up of terminologies. Grievances and appeals are very distinct, very different. Okay. Grievances means almost they usually address any sort of complaints related to service or quality sort of concerns, right? But appeals specifically they challenge the denial of care or benefits. We all know this. We should know this distinction. Okay, formal grievance is regarding the service or quality complaint, but appeal is something different. It is the challenging the denial of care. So here, appeal and grievance are not the same. Okay, so obviously, this is not the true statement related to the question. Now, option C is limited to insurance coverage issues. Again, this is narrow because appeals may involve medical necessity or denied authorization or denied claim for service. Okay, but only limiting it to insurance coverage is a problem. Here, it may be true if at all it's not is. This is a definitive sort of particle over here. It's saying it is limited to insurance coverage issue is not the right answer. This may be a part of it. It's too narrow. Okay, now option D may be reviewed by patient advocacy groups. Here patient advocacy groups can support or assist a member in appealing, but they are not formal decision making review bodies, right? So this is not a formal body. They may assist in appealing, but this is not the formal body. They can't review it. They can only support and assist. So this is also not the right answer. Now, may be reviewed by an independent external process. Yes, because after an internal appeal fails, okay, members or even the healthcare providers can also request an external sort of independent review by an outside entity. Okay, that is independent review organization. So which is not related to MCO or to the healthcare providers. That's a part of the appeal.
Excuse me, sir.
Yes.
Sir, this appeal means there is some grievance, and after that, they are filing the appeal, right?
No, no, no. Here the question is asking regarding appeal following the denial of care. They're not talking about the grievance or a complaint related to the service or anything within the hospital. They have applied for pre-authorization, they have applied for claims or something, but when the MCO denies that particular what do you say appeal authorization or the claim, the party have the option of appealing against that decision. That's appeal. That's not grievance. Grievance is like I take service from the organization, from a healthcare provider. I have something related to delayed sort of appointment, or I don't really like something within the process, and then I'll raise a formal grievance with the
Oh,
MCO, my sort of disappointment or my sort of problem within the care process. I hope you understand the difference between the formal grievance and an appeal. That's what I started with. Okay. I hope you understood this particular distinction.
It's clear.
Right. Thank you. So we'll be moving forward. Now, coming to the next question. A community hospital has 4 urologists in the specialty, all of whom share a practice. When a new solo practice urologist arrives and receives membership in the medical staff, and then and then concerns arise as to quality of surgical care, the best way to avoid conflict of interest issues is to option A, have each urologist sign a confidentiality agreement. Option B, have each urologist review the cases and issues independently. Option C, have only the one urologist who is head of the group handle the entire review. Option D, have a urologist from outside the group conduct the review. Okay, to prevent bias. So, what's your answer for this scenario? They have given a simple scenario.
Option D, provide some external review, doctor, to prevent
Right,
biases.
right. Option D. So simple. This is a straightforward scenario, but in a way, like you should understand where to focus on as far as such scenarios are concerned, always remember, while going through the question, you'll have to identify the keywords, you'll have to identify certain things. In case if you don't find, or if you miss out on those keywords at the first time when you're reading the question, after going through all the options, then again go to the question back and look for things which are addressed in those options as well, because this is very much important to deduce what the right answer is. Okay, so here in this particular scenario, a new urologist who is practicing solo has joined a hospital where already 4 urologists are practicing together as a group. Okay, so now in this scenario, there are quality concerns about this new doctor surgeries. Now, because the existing 4 all work as one group, they obviously have ties with each other, right? So in a way, like that may be their business adjustment, or anything, whatever it may be. So here there's a possibility, there's a possible sort of competition, or a possible sort of insecurity within that group sometimes. So to maintain the fairness, the question is asking, how do you review this case fairly, avoiding conflict of interest? That's the question. So you know the problem, you know the situation, and here the question is asking, here lies the clue for the answer: avoiding conflict of interest. As simple as that. Okay, so now when you go through, there are 4 on one side, 1 on the other side. The concerns are with the surgeries of the new urologist. If at all we choose one from this 4, or if we choose all 4, obviously there might be, or there's a possibility of having a sort of conflict of interest, because they are in a, they may feel it as a competitive, or a sort of business competition from each other. So it may not be intentional, but unintentionally there might be some sort of bias. There might be some sort of conflict of interest if one of them or all of them review his cases. So in such situations, obviously, an ideal thing would be call in someone from outside the group to conduct the review and get through this process. As simple as that. So option A, have each urologist sign a confidentiality agreement. This is not going to help us, because this is privacy of information and not related to bias. Okay, so this is not going to help anything. Have each urologist review the cases and issues independently? Obviously no. Okay, I mean, like all 4 belong to one group over, right? So even if they do it independently also, they may not come out clean. There's a slight possibility of bias or conflict of interest. Now, have only the one urologist who is the head of the group handle the entire? Obviously no, because this again, there's a concentration of decision making in a single person from that very group. So obviously there might be some competing interest. Again, I don't go with that option. Have a urologist from outside the group conduct the review? Obviously, this is the right answer, because there are no financial or professional stakes. So he's an outsider. He has no competitive relationship either with the new solo practitioner or with their group. So obviously he is going to be fair enough. So option D is the right answer. Next question. The appraisal of individual practitioners' performance in healthcare beyond minimum standards and criteria is known as CQI. Is it intensive analysis? Is it perceptive quality? Or is it peer review? What is it?
Peer review. Option D.
Option D, peer review. Right. So this is a straightforward question again. So the question is asking, like, when we are going through the practitioner evaluation or something in healthcare, there are minimum standards and criteria. There are minimum standards and criteria, but here the question is asking beyond minimum standards and criteria is what? So here beyond minimum standards and criteria is like there are rules, simple sort of checklist, that may be a sort of credentialing verification. Yes, he's an MBBS, he's an MD, he's this, he's that, right? Everything, right? That's a simple checklist sort of thing. That's a bare minimum standards and criteria. But the question is asking beyond it. Okay, so first option, continuous quality improvement. Again, this is organization wise, process focus, not on individuals. So again, this is not the one which you are going through. Intensive analysis. So this is not a recognized standard term for practitioner appraisal. Okay, so this is not the right answer. Perceptive quality. See, this is again, this is not standard also. Again, it's in context. It looks I mean, like appealing, but no, this is not related to individual practitioner performance. Peer review, yes, this is a standard sort of term that we use. Agreed. Where the practitioners of the same specialty or expertise, they evaluate the another practitioner's clinical judgment and performance. Okay, here they go beyond minimum standards. In minimum standards, we go through credentialing and everything, but here in peer review, the clinical judgment comes into play. Okay, so the professional judgment comes into play, their expertise comes into play. That's more of a qualitative data, right? So beyond minimum, obviously, this is going to be a peer review. Simple sort of question that. Next question. What of the following is the greatest benefit of concurrent clinical review? What's the greatest benefit of concurrent clinical review? Ability to focus review on prioritized performance measures, ability to review outcomes of care and process, timely assessment of the onset of care for continuity, or timely intervention to reduce risk of adverse outcomes. What's your answer?
Option D, timely intervention to reduce risk of
Right, timely intervention. Here, the question is the greatest benefit of concurrent review, concurrent clinical review. Concurrent is like it's while the treatment's happening, right? Now, coming to option A, ability to focus review on prioritized performance measures. This is more about review, structured review. This is not something unique to concurrent review. Okay, so you could prioritize measures in retrospective review also. That is not the greatest benefit of concurrent thing, right? Now, ability to review outcomes of care and process. Here, this is more related to the retrospective review. Okay, so since you know the outcomes fully, okay, after the care is completed, here, the concurrent review is limited in judging final outcomes, right? But here, ability to review outcomes of care is more of a retrospective review thing. Timely assessment of onset of care for continuity. So here again, um, this touches on timing of concurrency, but it frames around the care coordination rather than real sort of biggest benefit of concurrent review. Okay, so this is a way related to concurrent review, but here the term is greatest benefit out of all the options. Timely intervention to reduce risk of adverse outcomes. Yes, this is the true unique power of concurrent review, because the patient is still being treated. A reviewer can catch an issue, a developing problem, and can act immediately. Okay, so this actually changes the course of care in case if there was any harm that was involved. So the timely intervention is the biggest advantage of concurrent clinical review out of given options. So option D is the right answer. Okay, now coming to the next question. In conjunction with hospital credentialing, clinical privileges are granted to whom? Only to members of medical or professional staff, to all employees performing clinical procedures, to all licensed independent practitioners, only to active members of the medical or professional staff.
B.
option C, to all the licensed independent practitioner.
Okay, what was the another option? Someone told me option B also.
B for boy.
Right. Okay. So the house is divided between two options here. So let's see. Here the question is asking like when a hospital credentials a practitioners who actually gets clinical privileges. Okay. Who gets this? Every clinical employee or only key staff members or someone special? Okay. So here, the very much important thing is in conjunction with hospital credentialing, clinical privileges are granted too. Okay. Now, in conjunction with hospital credentialing, privileging is tied to credentialing process, especially for those who practice independently. Okay, this one thing which we should remember. Okay, this is very much fair. Now, option A, only to the members of medical professional staff is too narrow because LIPs can be granted privileges even without full medical staff membership. Okay, we all know only to the members of medical staff. Again, there is a certain class of LIP, certain class which is LIPs. They are granted. They undergo credentialing. They undergo privileging, even without being a member. So obviously, this is not the right answer. Coming to option D, only to active members of medical or professional staff. It's again is sort of restrictive because this excludes other staff like. Your telemedicine or allied health LIPs. Okay. They hold privileges within that organization even without being active sort of staff. So again, this is again restrictive. Now coming between the two. Option B, to all employees performing clinical procedures. It is too broad again. Unlike other two options, this is too broad because regular employed clinical staff like registered nurse or paramedics or technicians work under hospital employment and under supervision. They are, not through individually delineated clinical privileges. Okay, reserved for independent practice. Here, the distinction to all licensed independent practitioner means LIPs are again without direction or supervision within their licensure. They go through credentialing, receive the delineation of clinical privileges. Again, the only distinction between these two options is in conjunction with hospital credentialing, clinical privileges are granted to whom? Obviously, look here. Most of the time what's happens is for all employees performing clinical procedures, they will go through hospital credentialing process. They will also go through clinical privileges. But again, clinical privileges may be of two types. One is individualized, one is a sort of group. In group, let's say there is a newly joined, there are more than few junior nurses, registered nurses who have joined. They will get a blanket sort of privileges of what they can perform, what they cannot perform. Okay. This happens in few organizations. They may not go through a thorough evaluation of what they are able to do individually. Okay, there might be some new staff who are very much have an expertise in certain things, but by their sort of rank, by their sort of class, they are not allowed to do certain things and they are considered out of their clinical privilege scope. So the complete sort of credentialing and clinical privileging generally happens to the senior or the more independent staff and not for all employees performing clinical procedures. There's a fine line between these two options. To all employees, this is a blanket thing which we don't do for in conjunction. Means credentialing and also privileging should happen in the true sense. So to all employees performing clinical procedures, obviously I don't find fault for choosing this particular option, but there's a fine nuance between these two answers. To all licensed independent practitioners, yes, they are licensed independent practitioners. They go through credentialing and also individual clinical privileging. Okay. I hope you understood the difference between these two options, and the right answer is option C, to all licensed independent practitioners, because in conjunction with hospital credentialing and
Dr.
clinical
Nad-
privileges.
Dr. Nadine, can I ask
Yes.
you? To all license, they can be also new, right? Then independent
Yes,
LIPs can also be new.
yes, LIPs can also be new, but licensed independent practitioners, they go through individual sort of clinical privileging. When a new doctor joins
Okay.
in, see, they are evaluated individually. You can't club three or four doctors at a time and say yes, or you all get the same clinical privileges, right? That doesn't happen with
Okay.
licensed independent practitioners. As far as the other support staff is concerned, in a way like though they are
Oh,
clinical, the nursing staff or the paramedics or the technicians, they sometimes are privileged in group rather than being individual sort of things. So that's the difference between the two
okay.
options, right?
Okay. Thank you. Thank you.
Now, coming to the next question. Here, in the Xerox 10-step benchmarking model, the team seems to emphasize what QI component the most. Is it partnering or collaboration? Is it identifying customer needs? Is it innovation or is it prioritization? What's your answer?
Option A.
Option A, partnering and collaboration. Right. That's the right answer. Because we all went through this Xerox 10-step benchmarking model in detail in the previous session. So this is more of a sort of straightforward question because benchmarking itself relies on partnering or collaboration with other organizations. Right. So this particular model is built around comparing your process against those of other organizations. Okay. So now this is very unique in a way. So, whereas the other things are concerned, like identifying customer needs, obviously this is done internally, and but this is not unique to this particular model. This is found in other QI processes as well. Innovation and prioritization are the byproducts of adopting best practices mostly, right? Innovation. And whereas prioritization is concerned, this happens during the planning step of what to benchmark. Okay, this is a tool within the model. This is not the thing around which the tool is built upon. The entire tool is like identifying what we need to compare, with whom we are supposed to compare. We need to partnering with them, collaborating with them, and adopting the good practices, right? So you can go through our earlier sort of session discussion recording to see the Xerox benchmarking model in detail, and you will know this is the right answer. Now, scenario based again. In the large healthcare community medical group, one general surgeon has a 8% rate for both superficial and deep incisional surgical site infections for cases performed from October through March, 60% higher than the average for the other general surgeons in the group. In conjunction with the medical director, what should the quality professional do next? Option A, compare with local and national average infection rates. Option B, determine the surgeon's risk-adjusted case mix and practice patterns. Option C, compare with the rates of general surgeons in other surgical groups. Or option D, take cases to the peer review body. So this is a scenario wherein one surgeon's surgical site infection rate is above his peers within the same group or the organization. Okay. So the scenario is asking, like, before doing anything, what's the next smart move to figure out if this is a real problem or just data artifact? Okay. What should you do as a quality professional alongside the medical director?
Option B, doctor.
B, yeah.
B, yes. B.
Right. Option B, determine the surgeon's risk adjusted case mix and practice patterns. That's the right answer in a way. So here, I hope you got the question right. Now, coming to this option of comparing with local and national average infection rates, this is more of a broader benchmarking step that is useful, but again, we can't jump straight to external averages and all, right? First, we need to understand the context. We need to see why exactly this particular doctor's rates are high. Okay. Now, Option B, determine risk adjusted case mix and practice patterns. Yes, because this is the next logical direct sort of investigation step to see as to what sort of cases this particular surgeon is handling. Is he handling sicker cases? Is he handling more complex cases or high risk patients? Because obviously in such situation, the chances of the infection may be high because of the sort of there may be more emergency or contaminated cases that he's seeing when compared to his peers in the group, right? So that may partially or fully explain why his rate is elevated. Okay. In case if that doesn't fix, if his case mix index is similar to what his peers are, then we can look into the other steps. But here, in this particular scenario, it is very much important for us to see his case mix index before actually going further, right? So this is the next best logical step. Determine the surgeon's risk adjusted case mix and practice patterns, because in earlier sessions also we discussed in detail that we are supposed to compare apples to apples, oranges to oranges, and we are not going to see two practitioners under the same lens without actually adjusting for the risk, right? Risk adjustment is mandatory before comparing properly. Now compare with rates of general surgeons in other surgical groups. This is again like external benchmarking. We can't do it as of now. Eventually we can, in case if it's needed. Take cases to the peer review body. This is almost like jumping the gun, right? So we should first understand why that variance is happening, and after that, if everything goes off, then probably we can actually go for peer review of his cases in case if we find any sort of if we want any expert sort of analysis of his cases. Okay. Now, coming to the next question. Clinical performance measures in disease management programs are based on, simple straightforward question, standards of practice, clinical privilege criteria, clinical pathways, or practice guidelines. What's your answer?
Practice guidelines.
Right, practice guidelines. The question itself asks like, when you are building measures to see how well the disease management programs happen, like for diabetes or heart failure, whatever it is, to see whether they're performing clinically well or not, what's the source of these measures. Okay, we already went through in our previous sessions of clinical practice guidelines that we can actually reduce clinical performance measures because they are obviously evidence based, right? They are based on research. They are based. They're based on expertise. Okay, so here standards of practice is a broader, more general concept. That's not something, not specific evidence-based framework, right? So standards of practice is not something which we go through. Clinical privileging criteria, this relates to credentialing privileging and not related to disease management process. Clinical pathways is a practical operational tool. Okay, step-by-step care. So this is not the original source of evidence-based something, right? So this is also taken out. So the clinical practice guidelines, as you know, are the direct source for disease management performance measures. Okay, because they are evidence based. They are recommended by experts. They are based on research.
Sorry, Dr. Nadeem, is clinical pathway also not based on research or just
No,
I'm
it
new
is.
to
It
this?
is. Yes. Right. Clinical pathways are more of a practical tool to be adopted in the process. See, clinical practice guidelines, there you will get to know regarding one particular disease. For example, if it is related to what do you say, diabetes, there are clinical practice guidelines are based on the research, based on all the journals that is published. From there, we deduce the clinical practice guidelines for disease management of diabetes. That's how clinical practice guidelines are. But in case of clinical pathways, see, clinical pathway is something which we use internally in our organizations, where step A is supposed to be done before step B is supposed to be done before step C, and so on. I hope you got it. A, B,
Yeah.
C, D.
Okay.
Right?
Okay. Thank
So
you.
we do
Yeah.
have clinical pathways for, you say, stroke program. Once the patient comes, within 15 minutes, we are supposed to transfer that patient to the CT center to get his head scanned. Right? So
Yeah.
after that, after we are supposed to review the imaging, and is it a thrombolytic or a hemorrhagic stroke? Some thrombotic or hemorrhagic stroke. Then we need to decide which pathway we need to go. That's the clinical pathway. But as far as practice guidelines are
Okay.
concerned, that is more related to disease management programs. Okay.
Okay, thank you.
Right. Now, coming to the next question, accreditation credentialing requirements generally include. Okay, so option A, appointment to the appropriate category based on activity. Option B, current adequate malpractice insurance coverage. Option C, compliance with policies and procedures. Option D, history of loss of or limitation of privileges to practice. So here, let me make you the question make you understand the question. When accrediting bodies define what must be checked during credentialing, okay, they come up with some standard. They define what should be checked during credentialing. Which of these particular, which of these is a standard specific item they require verification. Okay, so go through these options: appointment to the appropriate category based on activity, current adequate malpractice insurance coverage, compliance with policies and procedures, or history of loss of or limitation of privileges to practice. What's your answer?
Let's see.
Okay,
Option D, privilege to
option D.
practice.
Uh,
Mm.
Right. Okay. So here you need to understand accreditation credentialing requirements. Okay. So this is something which is which an accreditation body is defining. Okay. Right. Now let's go through each option. Appointment to the appropriate category based on activity. This is something which we get through our medical bylaws. This is not something which is dictated from outside or through a accreditation standards. Let's say, for example, we are going to look into JCI standards itself, or it may be Sipahi or Gahar or what may be. Right? Appointment to appropriate category based activity. This is more of an internal organizational sort of thing. This happens after credentialing is completed. Okay. So after credentialing is done, in which category this person is supposed to be put into, that's something which is internal. This is not mandated by any accreditation organization. Now, current adequate malpractice insurance coverage. Right. So this is more of, again, an internal business or administrative requirement. Sometimes this may be regulatory also. In some places, this may be regulatory also, but this is not tied to any accreditation standard at all. Okay. Now, option C, compliance with policies and procedures. Okay. This is in a way that does fit, but this is more of a vague and generic. Okay, it doesn't describe a specific verifiable credentialing data point. Here, this is more related, the question is related to credentialing requirements. Okay, compliance with policies and procedures, obviously, this is something which may be related to accreditation, but that is not specific to credentialing requirement. Okay, now option D, history of loss or limitation of privileges to practice. It's simply like, you see, it's checking whether an applicant has ever had privileges denied or reduced or suspended or revoked at any facility before this application. Right? Because once we get to know this, there might be some there are the signs of potential competency or conduct issues. This is something which each organization asks in the application of a medical practitioners most of the times, and this may be a regulatory requirement also, and this is also an accreditation requirement, because this thing is supposed to be documented within the practitioner's file as a standard. Okay, in case if at all his privileges were reduced or limited or revoked earlier due to any issue, that may be due to his competency, that may be due to his general conduct, or whatever it may be. Okay, this is something which is asked in the application itself, and during credentialing they do go through this, and this is something which is also related to accreditation. This is also related to internal process. This is also related to regulatory process also. But whereas the first two are internal, third one is accreditation related, but not credentialing requirement. I hope you understood why option D is the right answer.
Yeah, clear. Thank you.
Right. The observation and evaluation of a new licensed independent practitioner or an LIP with newly requested privileges is known as. The observation and evaluation of a new LIP with newly requested privileges is known as application process, credentialing, proctoring, privileging. What is it?
Proctoring. Option C.
Right. Option C, proctoring is the right answer. We all know the question is asking regarding the observation and evaluation for a newly requested privilege. Newly requested privilege. Here we assume that the practice. I mean, like you see, here there's a new LIP. He's requesting new privilege. Okay, so obviously we know from earlier sessions that there is a certain period of observation and evaluation by more senior, more expert sort of person who's watching over his activities to judge whether these privileges can be given fully or not, right? So what is that process called? Is the question. Here the application process, this is the initial stage, more paperwork, and here we don't generally see the actual clinical performance, right? So this is not. Credentialing, again, that's the background verification of qualifications and everything. So his training, his education certificate, his licenses, references, again, this is not the observation of his practices. Privileging, again, so this is the formal granting of specific clinical privilege. Okay, this is decision made after observation and evaluation. So this is also not right. Proctoring, as we all know, the term proctoring is real-time direct observation of the process. Okay, here a more experienced or qualified colleague of his will watch this new practitioner or with new privilege performing actual cases to see how competent he is in doing those things, right? Before granting full privileges. So proctoring is the right answer. Like when you attempt your CPHQ exam, there is live proctoring, right? There is either, if you are attempting it in the center, obviously the center guy is proctoring you, he's observing you. Whereas if you attempt it through online, there's a live proctor who is watching you from the webcam, right? So just to remember that proctoring is a live observation and evaluation of how that person is doing. Then the basic philosophy of benchmarking is option A, eliminating the competition. Option B, finding best practice and incorporating it. Option D, getting all processes under statistical control. Option D, eliminating process deficiencies. What is it?
Option B.
Option, sorry?
Option B, Dr. B.
Right, option B, finding best practices and incorporating. Obviously, this is a straightforward question. We all know what is benchmarking. Benchmarking is something which we select a process to improve. We see the best in the business who is actually doing that particular process better than us, then trying to observe, adopt that particular practice and incorporate in our daily work. That's what benchmarking is all about, right? Eliminating competition, again, see here again, benchmarking actually involves learning from competitors. It's not eliminating them. So this is removed, getting all process under statistical control. This is more of a statistical process control, SPC. It's QI tool, not related to benchmarking. Eliminating process deficiencies. This is more of a Six Sigma thing, right? So the right answer is finding best practices and incorporating it. The next question is, a child is experiencing repeated asthma attacks at school. Arrangements are made for her to be seen at a new clinic. The physician utilizes evidence-based treatments for childhood asthma accepted by their specialty. Such descriptions for specific clinical conditions are best known as standards of practice, Clinical practice guidelines, clinical process policies, or clinical pathways? What's your
B.
Clinical
answer?
practice guidelines.
Right.
B.
Both
B.
of you answered the same. Clinical practice guidelines, because here we see this is related to evidence-based treatments. And this we have discussed in detail in the previous question, also related question. It's clinical practice guidelines. Right. With that, we finish the quiz on benchmarking, and we will move towards the introduction of accreditation now.